السلام عليكم أعزائي الطلاب. أرحب بكم وأتمنى لكم الصحة والسلامة والموفقية. إن شاء الله راح نتحدث اليوم عن المحاضرة رقم 8 بالinfectious disease. Scarlet fever, also known as the scarlatina, is a diffuse erythematous eruption that generally occurs in association with pharyngitis. Development of the scarlet fever rash requires prior exposure to Streptococcus pyogenes and occurs as a result of delayed type skin reaction to pyrogenic exotoxin, which are erythrogenic toxin, usually types A, B, or C produced by organisms. The rash of scarlet fever is a diffuse erythema that blanches with pressure with numerous small papular elevations, giving a sandpaper quality to the skin. It usually starts in the groin and armpits and is accompanied by circumoral pallor and a strawberry tongue. Subsequently, the rash expands rapidly to cover the trunk, followed by the extremities, and ultimately desquamates. The palms and soles are usually spared. The rash is most marked in the skin folds of the inguinal, axillary, antecubital, and abdominal areas and about the pressure points. It often exhibits a linear petechial character in the antecubital foci and axillary folds known as the Pastia's line. The diagnosis is established based on clinical manifestation, sometimes for rapid streptococcal testing and throat culture. Scarlet fever with pharyngitis can predispose to acute rheumatic fever. The approach to treatment of scarlet fever is the same as that of streptococcal pharyngitis. No additional treatment is warranted for the skin rash. Children may return to school or daycare 24 hours after initiation of antibiotics. No additional monitoring for such patients is required. Streptococcal toxic shock syndrome is a rare complication of streptococcal pharyngitis associated with shock and organ failure have been reported with increasing frequency. These infections have been termed streptococcal toxic shock syndrome. The most common portal of entry for streptococcal infections are the skin, vagina, pharynx, and mucosa. However, the portal cannot be ascertained in 45% of cases. Brucellosis is a zoonotic infection transmitted to humans from infected animals like cattle, sheep, goats, camels, pigs, or other animals by ingestion of food products such as unpasteurized dairy products or by contact with tissues or fluids. It's the most common zoonosis worldwide, and is an important public health problem in many developing countries. Endemic areas for brucellosis include countries of the Mediterranean basin, Middle East, Central Asia, and other countries. The most common mechanism for transmission of brucellosis to humans are consumption of infected and pasteurized animal products, contact of skin or mucous membranes with infected animal tissue, or infected animal fluids such as blood, urine, or milk, and inhalation of infected aerolized particles. The incubation period is usually 2 to 4 weeks. Occasionally, it may be as long as several months. Brucellosis typically presents with insidious onset of fever, malaise, night sweats, associated with a strong moldy odor, and arthralgias. Physical findings are variable and nonspecific. Hepatomegaly, splenomegaly, lymphadenopathy may be observed. Lab findings of brucellosis may include elevated transaminases and hematologic abnormalities, including anemia, leukopenia, or leukocytosis with relative lymphocytosis and thrombocytopenia. Complications of brucellosis include infection involving one or more focal sites. Any organ system can be affected. Osteoarticular disease is the most common form of focal brucellosis. It occurs in up to 70% of patients with brucellosis. Brucellosis should be suspected in patients with relevant signs and symptoms, like fever, malaise, night sweats, and arthralgia. In the setting of relevant epidemiologic exposure, a definitive diagnosis may be made by culture of organisms from blood, body fluids, or tissues, or 4 or more-fold rise in Brucella antibody titer between acute and convalescent phase serum specimens obtained 2 or more weeks apart. For patients with suspected brucellosis, blood cultures and serologic testing should be performed. In addition, laboratory studies include complete blood count and liver function test should be obtained. For patients with negative blood cultures and negative serologic studies, further investigation should be guided by the clinical presentation tailored to individual circumstances. General principles of brucellosis treatment include use of antibiotics with activity in acidic intracellular environment, such as doxycycline and rifampicin, and use of combination therapy given high relapse rates with monotherapy, and prolonged duration of treatment. Escherichia coli, or E. coli, are normal inhabitants of the human gastrointestinal tract. When E. coli strains acquire certain additional genetic material, they can become pathogenic. E. coli are among the most frequent bacterial causes of diarrhea. Types of E. coli. First of all, enterotoxigenic E. coli survive readily in water and food and is one of the most common bacterial causes of dehydrating diarrheal illness in children under 2 years of age in resource-limited regions. Enterotoxigenic E. coli can also cause diarrhea among travelers to tropical regions and is emerging as a pathogen in resource-rich settings. It causes primarily watery diarrhea through plasmid-encoded toxin production. Second one is the enteropathogenic E. coli. Has been associated with sporadic diarrheal illness and diarrhea outbreaks, most commonly among children under 6 months of age in resource-limited countries. Strains are defined by their characteristic attaching and effacing effect upon interaction with epithelial cells and by the fact that they do not produce Shiga toxin. Third one is enterohemorrhagic E. coli, capable of producing Shiga toxin, especially those belonging to serotype O157H7, have been responsible for large outbreaks of bloody diarrhea, some associated with hemolytic uremic syndrome or HUS. Fourth one is enteroinvasive E. coli infection appears to be uncommon. Clinical disease begins as watery diarrhea that may progress to bloody diarrhea and dysentery. It's closely related to Shigella, and the same genes facilitated pathogenesis of both organisms. It invades the intestinal cells, multiplies intracellularly, and extends into the adjacent intestinal cells. Fifth one is the enteroaggregative E. coli, associated with a persistent and acute diarrheal illness among many demographic groups in both resource limited and rich settings, and may be associated with linear growth retardation. E. coli can be cultured readily from the stool under aerobic conditions. Supportive care with fluid electrolytes and nutritional management is the cornerstone of treatment of diarrheal illness. For patients with diarrhea who have a pathogenic E. coli identified on stool testing, we suggest not routinely administered antibiotic therapy. Antibiotic therapy, example with azithromycin or ciprofloxacin, is reasonable in patients with severe bloody or persistent diarrhea. Leprosy, also known as Hansen's disease, is an infectious disease caused by mycobacteria of the Mycobacterium leprae complex that involve the skin and peripheral nerves. Leprosy is an important global health concern. Early diagnosis and a full course of treatment are critical for preventing lifelong neuropathy and disability. Leprosy is probably spread by the respiratory routes, thus the means of transmission is not fully understood. In the United States, it's also a zoonosis contact with armadillos has been documented in some cases. Other risk factors include close contact with known cases, older age, genetic predisposition, and immune suppression. Leprosy is classified using the following categories. Number 1, tuberculoid. Number 2, borderline. Number 3, mid borderline. Number 4, borderline sorry. Number 1, tuberculoid. Number 2, borderline tuberculoid. Number 3, mid borderline. Number 4, borderline lepromatous. And number 5, lepromatous. Number 5, intermediate, indeterminate. In general, patients with high degree of cell-mediated immunity and delayed hypersensitivity present on the tuberculoid end of the spectrum with relatively few well-demarcated lesions. Patients with no apparent resistance to Mycobacterium leprae present on the lepromatous end of the spectrum with the numerous poorly demarcated lesions. Early physical exam findings include hypopigmented or reddish skin patches, diminished sensation or loss of sensation in involved areas, paresthesia, painless wounds, or burns, and tender enlarged peripheral nerves. Neuropathy and ophthalmic injury can also occur. The diagnosis is established when at least one of these physical findings is present, and a skin biopsy obtained from the leading edge of the skin lesion confirms the presence of acid-fast bacilli in a cutaneous nerve. Immunologic reactions are systemic inflammatory complications that occur either before treatment, during treatment, or months or to years after treatment has been completed. There are two types of leprosy reaction. Type 1 typically occurs in patients with borderline disease, and type 2 occurs in patients with lepromatous disease. Our approach to treatment of leprosy is as follows. For patients with tubercular disease, we suggest treatment with dapsone 100 mg daily and rifampicin 600 mg daily for duration of 12 months. For patients with lepromatous disease, we suggest treatment with dapsone, rifampicin, and clofazimine 50 milligram 50 milligram daily for duration of 1 year. Neuritis must be treated aggressively to try to prevent or minimize nerve injury and thus prevent deformity and disability. We suggest treatment of neuritis with corticosteroids. While on treatment, routine follow-up visits should be scheduled every 3 months. Visits should consist of a clinical examination, including assessment of the skin, nerves, limbs, and eyes, as well as laboratory studies to assess drug toxicity. Patient education is important. Disease progression during therapy is almost always due to poor adherence to treatment. Immunologic reactions are systemic inflammatory complications. In general, antimicrobial therapy should be continued in the setting of immunologic reactions, and patients should be reassured that the symptoms are not a reaction to the medications. Mild reaction without neuritis or ulceration can be managed with supportive care. For severe reactions with neuritis, we suggest prompt treatment with steroids to avoid permanent nerve damage. In such cases, rifampicin administration should be reduced to once monthly. Second-line agents for treatment of immunologic reactions are PUO or FUO, fever or pyrexia of unknown origin, defined as fever higher than 38.3 Celsius degrees on several occasions, lasting for at least 3 weeks, some use 2 weeks, without an established etiology despite intensive evaluation and diagnostic testing. The most important aspects of the evaluation of patients with FUO are to take a careful history, perform a detailed physical examination, and to reassess the patients frequently. The diagnostic evaluation may fail to identify an etiology in as many as 30 to 50% of patients. Most adults who remain undiagnosed have a good prognosis. So you should know the definition of PUO. The causes is so important of the PUO and the approaches or the investigations we can send according to the history and examination.